Good afternoon. Thank you for joining us for the webinar on promoting better pain management, precision decision support for opioid prescribing. The research being presented today was supported in part by a grant from the National Institute of Healthcare Management, and we are grateful for their funding. The research team has no conflicts of interest to report. Today's webinar will feature 5 presenters. We're all affiliated with the Center for Health Information and Decision Systems, or Chids, an academic research center at the Robert H. Smith School of Business. Chids is focused on the use of digital technologies and analytics to address healthcare problems. I'm Ritu Agarwal, Senior Associate Dean and Professor of Information Systems at the Smith School and co-director of Chids. I will initially frame the problem and context for the study. Following me, Margaret Bennett-O'Tear and David Anderson will describe the prediction models developed in this project. Kislaya Prasad will follow up with the discussion of the cost-effectiveness of our proposed approach, and Kendall Crowley will conclude the presentation and manage the Q&A. This project is motivated by the opioid epidemic, now commonly characterized as possibly the most severe public health emergency confronting the United States in the past several decades. Typically prescribed for the management of chronic pain, opioids are a class of drugs that include prescription pain relievers such as oxycodone, hydrocodone, codeine, morphine, fentanyl, and others. Extended use of these drugs is associated with many adverse outcomes, the most severe of which include addiction and death. The prevalence of such adverse outcomes is widespread, and more broadly, the social and economic losses from the opioid epidemic are quite simply staggering. Drug overdose is the leading cause of accidental death in the U.S., with 52,404 lethal drug overdoses in 2015. Studies suggest that the opioid abuse is driving this epidemic, with over 15,000 overdose deaths related to prescription pain relievers and 9,580 overdose deaths attributed to synthetic opioids. In 2015 alone, over 2 million people misused prescription opioids for the first time. Altogether, the economic burden of opioid misuse and abuse amounted to almost $79 billion in 2013. And according to new research released by Alterum, the economic toll of the opioid crisis from 2001 through 2017 is estimated to have topped $1 trillion. It is also noteworthy that the growth rate of deaths from opioids of both the synthetic and natural variety is sharply positive, underscoring the gravity of the crisis and the need for urgent action. Recognizing this, in the recent budget appropriations bill passed by Congress, the NIH has received a funding increase, of which $500 million is specifically earmarked for research that targets opioid addiction. How do we address this public health emergency? One promising strategy that has been gaining traction in recent discussions in policy and clinical circles is that of early prevention. For a majority of patients, the first contact with an opioid occurs as a result of a doctor's prescription. Simply put, if the prescription is never written, or if the number of such prescriptions is reduced, then it is possible that we can reverse the trend of opioid addiction. However, determining if and when opioids should be prescribed when a patient presents with pain is a challenging task. Informing physicians about the potential adverse consequences of a regimen of opioids for a specific patient may represent one mechanism for modifying treatment approaches for pain management. Such an individualized approach requires the development of prediction models that allow prescribers to assess the ex-ante patient-specific risk of prescribing opioids. That is, the likelihood that the patient may eventually abuse these drugs and suffer from opioid disorder complications in the future. This is the broad focus of our research. We use an array of sophisticated modeling approaches, including machine learning, to construct these models. Then, we examine the cost-effectiveness of changing prescriber behavior. I will now hand over to Margaret to talk about the specific study goals as they relate to the risk prediction models and our findings.
Thank you, Ritu. So the goals of the study were to investigate the feasibility and accuracy of automated decision support for opioid prescription. In particular, our goal is to investigate this question both in a data-rich environment where automated decision support can be implemented based on an electronic health record, but equally importantly in what we call data-poor environments, where either there is no electronic health record or where implementing an automated decision support system is cost prohibitive. And we want to investigate how early the alarm can be sounded. Therefore, we study risk predictions in the first month of opioid prescription, the second and the third month. In this study, we used data of the members of the Army, around 825,000 individuals over 3 years. We excluded any members that were diagnosed with opioid abuse or dependency prior to the study period. Our dependent variable is chronic opioid use. That is, at the point of prescription, will the patient become a chronic opioid user, which we define as having at least 15 days supply in each of at least 3 out of the 4 next months. And again, we study this dependency in the first, second, and third prescription months. Although the Army population is in many ways unique, it's worth noting that the prevalence of COU, or chronic opioid use, is similar to what studies have found in the civilian population. For this study, we combined 5 different databases to construct our research dataset, consisting of almost 240 independent variables. Some of these variables are typical of any healthcare study, such as age, gender, diagnosis, procedures, and prescriptions, but other information reflects the reality of the Army population and some of their unique healthcare data, including information about deployments, self-reported data from mandatory health screenings, and very detailed information about BMI. With these variables, we implemented a number of machine learning algorithms to compare their insights and performance, starting with logistic regression. So what we are seeing here is partial results from our logistic regression models. What we found is that the results reflect many of the observations in the literature, such as the importance of duration of the initial opioid prescription, which we measured as increasing the odds of COU, or chronic opioid use, from 8 to 10-fold. If the initial prescription was for more than 7 days. We also found both musculoskeletal issues and pain diagnosis to have large effect on the odds of COU. We also consistently find an association between psychotropic prescriptions and chronic opioid use. The area under the curve, or the AUC, is a measure of a model's overall performance. The AUC can be interpreted as the probability that a randomly selected COU member will score higher by the model than a randomly selected non-COU member. For logistic regression models in month 1, the AUC is 0.89, and it's 0.86 for both months 2 and 3, so it's quite high, equal to or surpassing the highest AUC published in the literature. However, the goal of our analysis and insights is the intervention and prevention of COU through better decision support. And the low prevalence of COU plays a major role in how useful these models are in terms of patient targeting. In the first month of opioid use, our prevalence of COU is only 0.83%, meaning that at the point of prescription in the first month, there is less than 1% chance that a member goes on to chronic use. This affects the positive predicted value, which is a measure of how effectively we can target members at risk. The positive predicted value tells you the fraction that goes on to chronic use from all the members you label at risk. Therefore, if our goal is to capture half of the members who go on to chronic use, meaning you would calibrate your model to having a sensitivity of 50%, and that corresponds to the top row in this table, then the corresponding positive predictive value would only be 0.07, meaning less than 1 in 10 of the patients you label at risk would go on to COU without an intervention or any change in the prescription practice. In contrast, if we target only the highest risk members and target 1% of the members who are truly at risk, corresponding to the last line of this table, then the positive predictive value, or the PPV, is 39%, meaning almost 2 in 5 patients labeled at risk are correctly identified, and this corresponds to labeling 0.2% of the population. So we cannot target everybody, but we can efficiently identify the members who are at the highest risk. As I mentioned earlier, our goal is to develop as accurate models as possible, and therefore we applied and implemented numerous different algorithms, including advanced ensemble methods. What we found is that our carefully trained logistic regression models have the best overall performance as measured by AUC. However, adaptive boosting models outperform others where it matters, meaning they are the most accurate in targeting small amount of members at high risk, although the difference is not that large. So how effectively can we target members? It's a function of two things: the prescription month and the prevalence increase, and it's a function of two things: the prescription months as the prevalence increases as patients continue their opioid treatment, and how large of a population we would like to target. In this figure, we have the percent targeted on the x-axis and the positive predicted value, or the PPV, on the y-axis. As we can see in month 1, if we would like to target the top 1% of the population, we get a PPV of about 15%. However, as patients enter their second month of opioid prescription, the PPV is much higher, and we can now target around 2% of the population with a PPV of 20%. And then in the third month of opioid use, the PPV is even higher. We can target 2% of the population at a PPV of 25%, and around 7% of the population at a PPV of 20%. Given the performance of the models and the prevalence of chronic opioid use, a decision support system for COU should focus on the highest risk patients. With our models, there's certainly the opportunity to change the discussion with and potentially the treatment of the highest risk patients. I will now hand it off to David.
Thank you, Margaret. So as Margaret said, in addition to generating full machine learning algorithms that would require integration with an EMR system and a robust IT infrastructure, we also wanted to generate small parsimonious models that use as few variables as possible while still maintaining their predictive power. These small, simple algorithms have two big advantages. One, they're easier to implement. They take less time to input by hand. They have lower data requirements. And two, they're easier to understand. They make it obvious what the important variables are and what the determinants of future chronic opioid use are. So our end goal would be models that don't even require a computer at all, that we can implement in a data-sparse environment like an outpatient setting that can be done with pencil and paper or just with your fingers. So to do this, we started building up parsimonious models where we would look and try to find the best models that have just one predictor variable, two predictors, three, all the way up to 10. And we do this by fitting adaptive boosting models because they had that best performance at the very lower left-hand corner of the ROC curve. So these models tell us which ones are the most important for predicting future chronic opioid use. And they still require computer implementation. These boosting models are computationally intensive, but they're much smaller and they can be entered by hand into a web interface or something like that. So they're easier to implement even though they still require a computer. These models were generated by first selecting any variable that was significant by itself as a predictor of chronic opioid use, which winnowed our data set from about 240 variables down to about 50 that were candidates. And then we did exhaustive search of the best 1, 2, and 3 variable models, and then forward selection from there to build up to the best 10 variable model. So our one variable model for month 1, the most predictive variable was the number of psychotropic drugs you had taken in the previous 4 months. So it says the most important characteristic for the first month of patient is their underlying mental health status, more or less. And then when we augment that up to a 2 variable model, it's your psychotropes and then how many days of opioid supplies you get. So that we see that for patients initially, the most important thing is mental health status and the amount of drugs that they get. And when we augment it up to, say, a 5 variable model, we have those initial 2 plus demographic information like the installation that they're at, their education, their marital status. These are the sorts of things that get taken into the model there. And if we look in month 1 with a 5 variable model, so much smaller than these big, huge models that Margaret discussed, we still have a 17% positive predictive value. So in that top 1% of patients, we can reasonably accurately identify patients who are at high risk. And again, if we increase our target population to 2, 3, 5, 10% of the population, the positive predictive value goes down, but the trends are sort of the same. That we can build models that are just as good as the overall population by only using 5 or 6 or 7 variables. So that works very nicely, that we're able to reduce the number of variables used while still maintaining that predictive power. In month 3, the story is similar, but again, our positive predictive values are better because by the time you've had 3 months of opioid prediction, you're sort of halfway down the pathway to chronic opioid use. So that more people have COU, there's higher underlying prevalence, so our positive predictive value can be better. And again, the first 2 variables that we use in the 3-month models are days of opioid supply and psychotropes. They switch order, but still the main 2 are how much opiates you've been given and your underlying mental health status. But now when we build up to a 5-variable model, we get more information about the patient's health status and their treatment path. Because they've been in the system longer, we have more information about them. Things that start to matter are their pain scores, their number of times that they've complained about pain, and then the types of opioids that they've been prescribed. So we see there, and again, as we increase from 1 to 2 to 3 to 5 to 10%, the positive predictive value goes down, but we're intervening in a larger part of the population. So that's a trade-off that we can consider. So the takeaways are, in month 1 and month 3, the most important things are mental health status and the amount of opiates that we've prescribed. But then in month 1, the things that really matter after that are just sort of markers of overall health and their demographics. So age, education, where they're located, marital status, those sorts of things. Whereas in month 3, we start to see patient-specific treatment and diagnosis things that are starting to come into play. So their pain scores, their number of behavioral health visits, these sorts of things. So that's there. But again, these models might still be too complex. They still require computer implementation, even if they're small. And our ultimate goal is a human computable algorithm. So something that can be done with pen and paper or fingers. So we want a fast, accurate, easy model that can be used by anybody anywhere. So examples of things like this are screening tests for depression, like we have the picture of in the upper right-hand corner of the slides here, or APGAR scores, which are used to evaluate infant health just immediately after birth, and all of these sorts of things. And to generate these models, we use SLIM, which is an integer programming-based optimization model that optimizes scores to balance our demands for accuracy and parsimony. So it tries to find the best model that it can while keeping it as small as possible. And if we look, if we compare the SLIM models versus logistic regression, we can get results that are pretty much essentially the same, maybe even a tad bit better, but much, much, much smaller and are computable just sort of using your fingers. So for the 1% of the population, if they have 4+ psychotropic prescriptions over the past 4 months, and if they get more than a week of opioids, we score them as positive. So that targets about 1% of the population, and we can see that that does just as well as our whole overall boosting model or logistic regression model does. If we want to target the top 5% of the population, the model says if you have more than a week of opioid supply and if you have any underlying mental health issues, so if you've ever had any psychotropic drugs, we're going to score you as positive. So we can see there, they're good, they're small, they're easy to implement, and their performance is just as good as any of the other models that we've predicted. So we can train similar models for months 2 and month 3 that are equally similar and equally simple and equally accurate. So a few challenges of this problem in this data set is we have good results on our population and we have actionable insights, especially in month 2 and month 3, but the rarity of the outcome leads to problems and low positive predictive value because it's just so rare. So our models perform well and they're simple and easy to understand, but there's sort of this problem that we have low prevalence, so that leads to not as high positive predictive value as we would like. And another limitation that we have is that our data comes from the Army. So soldiers may be systemically different than civilians somehow. It uses things like number of deployments, which if my doctor is prescribing me opioids, they're probably not going to be able to take into account. So adapting these models from the adapting these models from the Army population to the general population may not be straightforward, but we think the general methodology and the algorithms that we use should be pretty straightforward. And the second limitation is that prescription behavior is fast changing. Prescription practices, prescription guidelines are changing and constantly being updated, which means we should probably have to frequently update and revise the models to make sure that they stay current. And with that, I'm going to hand it off to Kislaya Prasad to talk about the cost effectiveness of interventions that target these at-risk patients.
Thanks, David. So in this first part of the webinar, we saw that chronic opioid use can be predicted with fairly high accuracy. Additionally, we saw that the opiate amounts prescribed are a useful predictor of chronic opioid use. In the past as well, physician prescribing behavior has been posited to be one of the causes of opioid dependency. And we, in our study, we find this to be the case here as well. So in this part of the webinar, we ask if a change in prescribing behavior can lead to reductions in chronic opioid use. Additionally, what would be the costs and benefits associated with such a change in prescribing behavior? One differentiating factor among patients presenting with pain is the number of days for which a physician prescribes opioids. As it turns out, longer prescriptions lead to greater opioid dependency in patients who might not progress to chronic use if they had received shorter prescriptions. Such chronic use is associated with a number of costs, healthcare costs, productivity loss, etc. We conduct a simulation study to estimate the cost savings and benefits being measured as days spent free of opioids, that would result from reassigning individuals from a long to a short prescription. So let me just briefly describe the outline of our cost-effective analysis study. So suppose that the amount a group of otherwise identical patients, suppose that among a group of otherwise identical patients, some get a long prescription, which, as in the first part of this webinar, we described to be 7 days or longer, while others get a short prescription, 3 days or fewer. The first question we must ask is it the case that we will see greater prevalence of chronic opioid use in the group with the long prescriptions? For the first part of our analysis, we construct, using propensity score matching, two groups with similar characteristics that differ in the length of the prescription. And we find, indeed, the greater dependence in the long prescription group. Now, if the health outcomes of the two groups differ, then arguably we could get the outcomes of the short prescription group by bringing about a change in initial prescription from long to short. The cost differences between the prescriptions themselves is small, but the costs associated with opioid dependency can be quite large. These could be stemming from direct health costs and productivity losses. And it's these costs in the long run that we're interested in estimating. We find that costs are lower for the short group, and the number of opioid-free days is actually greater. So in practice, changing prescribing behavior is unlikely to be costless, and so we build a Markov model and simulate the effects of changing behavior, in other words, a move in prescriptions from long to short. A standard measure of cost effectiveness is the incremental cost effectiveness ratio. This is the incremental dollar cost of obtaining an additional opioid-free. We compute these ratios at various price points for the prescription behavior modification intervention, and find such an intervention to be cost effective. So let me describe the first part that we need to establish, the matched sample analysis. To conduct the experiment, we require otherwise similar patients who differ only in the length of the prescription, short versus long. So in that case, moving people from the long to the short prescription group can be expected to lead to similar outcomes. So we use propensity score matching for this. Patients were matched on demographics, age, race, and education, for instance, on medical condition, other prescriptions, including psychotropic drugs, previous addictive behaviors, including alcoholism, BMI, etc. And finally, we include stated pain levels for the matching. These are interesting. As we note in the table here, differences are small. They're statistically significant, which is not surprising given the size of the sample, but in practical terms, the difference is small. The pain numbers, these are on a 10-point scale, happen to be noteworthy. At 4.7 and 4.3, they are low for both groups, though marginally higher for those receiving long prescriptions. Even excluding individuals from whom a score of 0 is reported, the average pain score is 5.65, near the middle of the scale. The corresponding number for the non-opioid data set is 4.69. So it's certainly possible that this young military population's pain scores are shifted towards the lower end of the scale, and so discounted by physicians when they prescribe opioids. So let me describe the simulation very briefly. The idea is very simple. We simulate the health histories of individuals over some time horizon using states to describe their health in any given period. So we'll simulate 24 months in the life of a cohort of patients who are prescribed opioids. Individuals in the simulation can be in one of a number of health states. The circles in the graph that you're seeing correspond to the states we model. These are the short, medium, and long states corresponding to prescription length. A patient could, for instance, be assigned to the long state corresponding to 7 days or more of opioids prescribed. The state called free denotes no opioid use. Dead and discharged, of course, are self-explanatory. COU corresponds to chronic opioid use, using the definition from the first part of the webinar. The arrows denote transitions between states. These occur with specified probability. Of course, an individual may remain in the same state as well. And the transition probabilities are things we estimate from the data. For the baseline simulation, a cohort of individuals is initially assigned to the long state, and then we run the simulation as they move from state to state for 24 months. The alternative simulation is the intervention. This cohort is assigned, in other words, reassigned to the short prescription state. In any state, individuals will incur state-specific costs. In our simulation, a period or stage is 1 month. There's also a per-period benefit generated. Its unit is a month lived free of opioids. So in states other than free, we'll adjust for quality of life. For instance, a month in the chronic opioid use state may be valued at 7/10 of a month spent in the free state. The graphs here will give you a sense of the progression of the simulation in terms of occupancy of states. On the x-axis, we have the stage running up to a total of 24 months. On the y-axis, we have the probability of being in any health state. Right? We have line graphs for each of the states. So you see the free and chronic opioid use labeled, and the others are sort of bunched at the bottom. The figure on the left describes the simulation where everybody starts in the long state. In the right figure, all start in the short state. Notice that people quickly leave the initial states and most people transition to the free state, and that's denoted in green. The most noticeable differences between the two figures are, first, the notable increase in the number of individuals in the chronic opioid use state in the left figure, which, recall, are people starting from the long prescription. The second thing, although that's not clearly visible, there's also a greater number of discharges from the military over time for people who start with a long prescription. So as mentioned earlier, for every month that an individual spends in a state, we incur a state-specific cost, which is then accumulated over the length of the simulation. In estimating costs, we adopt the employer's perspective, measuring direct medical costs and productivity losses. In particular, all societal or personal costs are disregarded. An individual with chronic dependency who's discharged from service will cease to incur cost, even though he or she is likely incurring costs outside of the military. So these are just the Army's costs. The first column in the table denotes the state-specific per-period cost, highest for chronic opioid use at about $3,065. And this is followed by long, medium, short, and free in that order, declining. Dead and discharged are the lowest, mainly because the military doesn't bear the costs. The direct medical costs were estimated by us from the data. Additionally, we estimated loss of productivity using data on duty restrictions, the value of a month being set equal to the monthly cost of a soldier to the armed forces. Early death and discharge involve replacement costs, for instance, training costs of a soldier, and we account for these as well. As mentioned earlier, we adjust for quality of life, the unit being a month in the free state. So in the under the title quali, you see for free, you see the number number one. And we show the quality of life of other months as well. So, for instance, COU is valued at 7/10. A month in the COU state is valued at 7/10 as a month in the free state. Some of these numbers are drawn from the literature, while we use assumptions for the other, trying out a range of assumptions about quality of life. And then we discount everything at a 3% rate. So this slide summarizes some of our key results. The first column is the per person average of the cumulative cost under the two alternative scenarios. The baseline, where the cohort is started in the long prescription, and the alternative, where they're started in the short prescription. The second column is the effectiveness measured in units of months in the free state. Recall that adjustments for quality of life mean that a month in some of the health states may be worth only a fraction of a month in the free state. The third and fourth columns are the incremental cost and effectiveness. So there's approximately a $5 million cost saving to the employer if 10,000 people are shifted from the long to the short prescription. The benefit is the equivalent of an additional 2,217 months spent in the opioid-free state. Note that the employer perspective disregards both individual and societal costs. For instance, once people are discharged, the only relevant cost is that of replacement. Additionally, the young and disciplined population prevalence of chronic use is quite low, and consequently, we might expect these costs to be much higher in other contexts. We see that costs are lower and effectiveness higher for the alternative, indicating that the baseline is dominated. At zero cost, a change in prescribing behavior would be warranted. However, a change in prescribing behavior need not be costless to obtain. So we consider additional program costs, assumed to be per person cost for the cohort, and then compute the incremental cost-effectiveness ratio. That's shown on this next table. This is the cost-effectiveness ratio. This is the additional cost of obtaining the equivalent of another year free of opioids. So at $500 per person, the baseline is still dominated, and even at a cost of $1,000 per person, the intervention would be considered cost-effective by conventional standards, the incremental cost being less than $50,000. So to conclude this part of the study, in our analysis of matched populations, we found that people with similar conditions appear to receive different prescriptions, and there is greater opioid dependency among people with long prescriptions. The difference in costs and effectiveness for these two groups allowed us to develop estimates of the cost savings and benefits in terms of opioid-free days of interventions that bring about a change in prescribing behavior. And the final conclusion was, even at moderately high costs of bringing about a change in behavior, such interventions would be cost-effective. With that, let me hand it over to Kenyon to conclude.
And actually, I'll hand it to Ritu.
Thank you, Kislaya. Thank you, Kenyon. We just heard from Kislaya about the cost effectiveness of our proposed approach, and prior to that, Margaret and David described the prediction models. I'm going to step back for a little bit now and talk about some of the broader implications of our findings and what some opportunities for future research might be. As we heard from Margaret and David, the accuracy of our models in the first 3 months of use, especially in the second and third months of use, are good enough to encourage a conversation, a detailed discussion between the physician and the patient about potential risks and alternative course of treatments for the highest risk patients particularly. In fact, some of the recent guidelines released by the CDC and other organizations suggest exactly that prior to the prescription of opioids for the management of pain, the patient and the provider should have a discussion and a conversation about alternative therapies, including things like acupuncture. Physicians should be especially wary of prescribing opioids for patients who are scored at being at the highest risk for chronic opioid use. As treatments with opioids is extended into the second and third month of use, the risk predictions become much more accurate and personalized. While we always worry about allowing opioid use to go into 2 and 3 months, we do know now, based on these data, that our predictions become much more accurate at those points in time. We also found that prescribing an initial opioid supply that exceeds 8 days raises the risk of COU significantly, and therefore providers should seek to prescribe at the clinically necessary minimum quantity and minimum duration for opioids. We found that the presence of a psychotropic prescription in general signals very high risk of potential COU, and prescribers should take extra caution. We also, on the basis of our research, can infer that any decision support system for chronic opioid use to inform clinical judgment in general should be set to focus on the highest risk patients, corresponding to a relatively small sensitivity value, such as between 5 and 10%. Any policy that brings about a change in prescribing behavior has the potential of reducing costs and improving quality of life. In other words, these are cost-effective policies that generate value, and at very plausible price points, such policies would be extremely cost-effective and desirable to use. Finally, we think there are lots of opportunities to take this research into the field, and I will ask Kenyon to say a few words about our translation opportunities.
Thank you very much, Ritu. These results are indeed very promising, and we believe offer the potential to help improve the evaluation of patient risk of chronic opioid use in a more precise and patient-centered way, which can empower prescribers. But however, frequently there's a gap between translating research innovations into practical applications, but it's not always the case. And as such, we are seeking to further develop and implement these modeling approaches with additional populations in other contexts. There may be opportunities to partner for analyses of real-world data sets where the prediction of opioid outcomes, risk, behaviors, and related variables may offer value, whether that's for clinical care, population health activities, or policymaking. Further, there may be opportunities to implement the simple scoring tools in a pilot network, or perhaps creating integrated decision support solutions with electronic health record data or complementary data sources. I imagine many of the individuals listening today are stakeholders concerned with improving pain management and/or reducing potentially unnecessary opioid use and the negative consequences of it, but also not wanting to restrict access to appropriate care, which may include prescription opioids in certain cases. Finally, at Chids, I'll note we are very passionate about unleashing diverse electronic health data in combination with cutting-edge analytical methods to improve health. And there's no doubt the opioid epidemic is one of our nation's most pressing public health crises. And in order to combat this epidemic, we'll take a variety of expertise and resources, spanning medicine, informatics, public health, policy, and human factors, to name a few. So we hope you will contact us to discuss potential partnerships, and we look forward to disseminating this information further and translating it into practice. So at this point, we're going to open the chat for Q&A. So please use the chat feature in your WebEx interface for your questions. Please send them to all panelists. We'll try to respond to as many questions as possible. We do have about 15 minutes for questions. So again, thank you, and then we'll have some concluding remarks, sharing some contact details and some follow-up information after the Q&A. So we look forward to your questions. Thank you. Okay, so we're starting to get some questions rolling in. So the first question, it's from Anton Avanov. So it says, hello, thank you for a great presentation. I have a question related to characteristics underlying the mental health status. Are there any specific psychological characteristics that indicated a particularly significant influence on the outcome? In other words, are there any distinguished risk indicators associated with the increased opioid use? Thank you.
So in our models, we had quite a few variables indicating different diagnoses of mental health issues. So what we found overall when we are focused on predicting chronic opioid use is that just using the indicators for the psychotropic medication actually captured all of those. So kind of to summarize, the psychotropic medication act as a summary of all mental health issues, and that is one of the reasons why they're so powerful in these prediction models. And since that variable is in the models, then other indicators of specific mental health issues become secondary and not that statistically significant. If we would remove the variable for the psychotropic prescriptions from the models, then I would foresee that some of these different mental health diagnosis would actually start entering the models. So you would see, depression or etc. in the models. But because we are using the summarizing variable, they become less important in the models.
And it's probably worth pointing out that the predictive ability of the psychotropic medication was amongst the highest, right? So
Correct.
Introducing any individual mental health states into the model would not improve the predictive power.
No, yeah. Very true.
Okay, thank you. And we now have a question about the cost effectiveness analysis. It says, I was wondering if there was any effort to validate the Markov model-based simulation results.
Yes, indeed, we did that. So I showed you those probability graphs. In the paper, we also have corresponding empirical probability graphs, and they look remarkably similar. So we actually tried to match even the output that we got out of the simulation to their empirical counterparts, and then and we did other standard consistency checks between the two. Yeah.
Mm-hmm. Okay.
David, if you would like to comment on that question, please go ahead as well. Okay, we seem to have
Oh, sure. So matching, yeah, we looked and matched we looked at the empirical, the transition states, sort of, if you built it empirically from the data, and it matched the Markov model pretty well. So I think we were happy with the transitions and those things. So if we were to augment it, one thing we would want to do is include a little bit of history into it, that, if people have been in 2 or 3 months, that it's not entirely memoryless, but in general it matches pretty well, and we were pretty happy with it.
Great. Let's see, we have a comment and a question. So what changed in the early 2000s till recently was the amount of opioids and pain management given to patients. It changed to pain being more subjective, and as nurses were told to meet that subjective need. I have always wondered if this affected what is going on presently.
I would say yes. Again, just based on what I have read and observed and summarized from the literature, it is indeed the case that more prescriptions for opioids are being written, and that is the proximal driver. At least it's been implicated as the proximal driver of the opioid crisis. I would surmise, I don't have any empirical data to back it up, that nurses are being encouraged to report higher pain scores. It's remarkable, as was pointed out in our presentation today, that the reported pain scores for our cohort of patients were actually pretty low. That means the physician and or the nurse practitioner or the clinical expert that the patient was interacting with was seeing some indications or some signals that would generate that opioid prescription. So yes, you are right. There is a high likelihood that what you've described is what's going on currently.
Mm-hmm. Yeah, and I also believe in the 2000s when we started treating pain as the fifth vital sign, became a sort of marketing strategy, and then instead of realizing that many individuals are going to have some level of pain, it became practice to try to completely eliminate pain, which has been discussed as being one reason that there was so much prescribing and spread of the epidemic.
And of course, in the national media, most recently, there has been a lot of discussion about the aggressive marketing tactics adopted for opioids. So that may play into the mix as well as to why we have seen such a sharp rise in prescriptions.
Thank you, Ritu. Do we have any other questions? Please put them in the chat. I will mention that we will make the slides available on our website, and we'll be sending that out to all the registered users.
We have two working papers describing the prediction models and the cost effectiveness analysis. And as soon as those are ready for sharing, we will post those on the website as well.
Okay, thank you. And let's see, we have a couple more questions that are rolling in. So thank you for your work. Did you all look at or consider how a tool like this might further restrict appropriate care for those who are currently under-prescribed pain medication?
That's a great question, and that's a discussion that our team has had often, and again, underscored most recently by the media's attention on patients who are suffering from pain and are not being prescribed opioids because of all the negative discussion. Yes, we are strong believers in personalized medicine. So to the extent that it's possible for a prescriber and a patient to have a deep, meaningful conversation about the patient's condition, and for the prescriber to be able to make an informed judgment on the basis of the risk factors that we've identified, and a host of other considerations. The prescriber should be able to make an informed judgment as to whether this patient truly needs opioids to improve the quality of their life because they're managing so much pain, or if there are alternative therapies. So I don't think there's a one-size-fits-all answer to that question, and certainly for such an important issue, it is critical that prescribers take the time out to make this decision carefully and thoughtfully.
And I'll add, and that was really behind our thinking in the matching study, which is that we wanted to find otherwise identical patients who were getting different prescriptions, and we only speak of reassigning those from one prescription group to other. And I think, as our matching analysis showed, those two groups are incredibly similar, but just happen to get different prescriptions. Mm-hmm. And so there's no sort of blanket recommendation. It's very conditional.
Mm-hmm. And I'll just note a comment from a participant that said, and on that point, under-prescription may also induce switching to illicit drugs. Maybe that should be integrated into a future prediction model.
That's a great idea. Yeah, thank you. We could simulate that.
Mm-hmm.
Yeah.
Okay, we have a question. Can you separate out soldiers that experience polytrauma, for example, TBI or significant injury? A priori, they would have more serious and long-term needs that would impact A, use of opioids, and B, likelihood of discharge for medical reasons.
Yeah, so we did have multiple medical variables in the models, and some of the variables that actually turned out to be significant were the musculoskeletal issues, which captures some of that. I don't remember, so I believe we have TBI in our data set, but it didn't pop up as significant. So that can be either because we don't have enough population experiencing TBI, or after accounting for everything else, TBI doesn't add additional predictive power to our models. But that's definitely something that we considered when we were building the models.
Let's see, we have a question. You mentioned that marital status and education impacted opioid use, or rather opioid risk. Can you restate or elaborate on what your findings were?
So I would have to have my models in front of me, which I don't. But for example, so in terms of the demographic variables, one thing that we see when we compare the risk or the odds of becoming chronic opioid user between whites and blacks, for example, being black actually reduces your odds of becoming chronic opioid user. And there are some hypotheses around why that is. One of those hypotheses is that doctors might be more reluctant to give black Army members opioids because of their own biases. Another thing that we looked at, another demographic variable that we looked at that is very Army specific is where they're based. And one thing we found that is if you are situated in Hawaii, you are less likely to become chronic opioid user. So these are two things I remember on the top of my mind. I would have to go back to my models to look at the other demographic variables. But if you email Chids, then I would be happy to answer those. In terms of the marital status, I believe, and don't quote me even though I'm on the record, if you were single, you were more likely to become a chronic opioid user. But again, I don't want to, if you're interested, please email me. I would be happy to answer it looking at the detailed output of my models before making any statements.
Right. I mean, just to reiterate, I think there were over 230 different variables in the model, which each had more or less significant implications on risk.
Some of them, yeah. So we found between 40 and 50 were, driving. Really, out of the 240 variables, around 40 or 50 were the ones that were driving the accuracy of the models.
I also want to underscore that today's electronic health record systems and other kinds of technology capture reams of data about an individual patient. But at the point of care, all of that data is not very useful unless it is very quickly synthesized into some actionable guideline for the prescriber. So just to remind everybody, when Margaret described the goals of our study, it was very much to come up with a risk scoring mechanism that is parsimonious and that is feasible to implement in real-world clinical practice.
We have another question. Was previous or lifetime history of physical or psychological abuse tested as a predictor variable?
Unfortunately, that's not a variable that is captured in this particular data set, but it would be an important consideration, and perhaps when we use a civilian data set or something from social services or some other source, we might be able to look at the effects of such a variable.
Yeah, and in our data set, we had some self-reported information about behavioral variables. So there's a mandatory health screening annual, I believe, where they are asked about their past use of tobacco, alcohol, etc., and it includes depression screening as well. So we have some of that captured in our data set.
Okay. Well, I don't see any more questions coming in, but thank you for the excellent questions and comments. Wait, one more question. How about combat exposure as a predictor?
Yeah, so we see that deployment is actually very important. So the number of deployments overseas. One thing that we want to expand upon is actually now the Army actually has a measure that not only just accounts deployments, but did you see battle? How extreme was your experience overseas? And that would be very interesting to include that additionally in our models. But we did include deployments as an indicator of combat exposure.
Okay. Great. So with that, I'm going to go ahead and wrap up the webinar. I don't believe there's any more comments from the team at this stage. I think it's been a robust discussion.
Not at this stage, yes. Thank you for joining us, and thank you for a robust discussion.
Okay, and again, so please stay in touch. We are very passionate about these results being disseminated, and there's a variety of ways to collaborate with us, and we also have a wonderful graduate and undergraduate students as members of the center who will be looking to sort of build out their analytics capabilities with organizations, perhaps such as yours. And again, we'll send a follow-up email, but on the screen now is some of our contact information. And I'll also mention that we'll have further discussions on health IT and analytics topics October 19th and 20th at DC, as we'll be hosting the conference on health IT analytics, which is also supported by HRQ and now in its 9th year. But all this will be posted to our website. And again, please get in touch. And thank you very much for joining us. And thanks again to the National Institute of Healthcare Management for their support of this work.